Okay. Well, thank you very much. So, my pleasure to introduce Dr. Neha Bhasin, who's an associate professor of pediatrics in the Division of Hematology at Oakland Children's Hospital. She's also the director of the UCSF Sickle Cell Center for Excellence and leads the comprehensive sickle cell clinics. Her research interests include reproductive health and sickle cell bleeding, thromboses, and associated anemias. She's been striving to optimize sickle cell care and develop evidence-based guidelines for individuals with sickle cell worldwide. It's obviously a very key global health issue, so really excited to have you. Thank you for joining us.
Great. Thank you for having me. So hi, everybody. I'm guessing everybody in the room is a medical student. Is that correct? No.
Well, we have a combination. So we have pediatric residents who are in the pathway from both sides of the bay. And then we also, this is a public facing session. So people who join are other individuals who are interested in global child health. So physicians, nurses, trainees.
Well, great. Okay, so yeah, the presentation hopefully is geared towards all those. Please ask questions in the end of the presentation. I know it's a long presentation, but you can always email me. I'll have my email in the last screen if questions come up, and for some reason, if we're not able to finish this presentation. So I will start as we're 8 minutes behind, but we'll get started. All right, so I will be talking about sickle cell disease, and really I'm a pediatric hematologist, so my perspective is very pediatric based. So obviously if you were to hear this talk from an adult sickle cell provider, you may hear something different, but I will talk from my experience and what I encounter in my daily practice. So as everybody So here's the objectives of my talk. We're going to go over a little bit of history about sickle cell disease, epidemiology, pathophysiology, complications, disease-modifying therapies, and transformative therapies in the end. In 1904, Walter Clement Noel, he was a 20-year-old first-year dental student. He was admitted to Chicago Presbyterian Hospital. He was suffering from anemia. He had had recurrent episodes of pain, and Ernest Edward Irons, he was an intern in the lab, and he looked at his red blood cells, and he said his red cells looked peculiarly elongated and sickle-shaped. Walter unfortunately died in 1916 from a pneumonia event, which we today call acute chest syndrome. And the first case report of sickle cell anemia was published in 1910. After this, actually before this, in the 1670s, there's reports in the African literature about children, and they were labeled as Ogbanjis, and that stands for children who come and go. And it was reported in multiple literatures prior to 1904. In 1940, Sherman reported that there was sickling of red blood cells in the absence of oxygen. So there was a phenomenon noted when there was less oxygen in the environment, red blood cells turned into this sickle shape. And this was the first time there was a molecular basis of sickle cell that was noted. In 1948, Dr. Watson suggested that there was something called fetal hemoglobin, and that patients who had a lot of fetal hemoglobin tended to have less complications of sickle cell disease. In 1949, Linus Pauling was the first to demonstrate that sickle cell disease occurs as a result of an abnormality in the red blood cell. This was the first time a genetic disease was linked to a mutation in a specific protein. And sickle cell disease, for that reason, has been known about for the longest period of time. Some history about Oakland. Oakland was the ground where the Black Panther Party was started in 1966. And this was started by Huey Newton and Bobby Seale, who were very disappointed in the failure of the civil rights movement to improve the conditions of Blacks outside of the South. So the members of the Black Panther Party confronted politicians, challenged police, and protected Black citizens from brutality. And in the community, this party created these survival programs and provided food, clothing, and transportation for Black people in the community. So Oakland has a long history of taking care of sickle cell patients for this very reason. In 1972, President Nixon signed the National Sickle Cell Anemia Control Act. And at that time, the act included improved screening and counseling programs, information and education activities related to sickle cell, and in addition to research grants in the diagnosis and treatment of sickle cell disease. Other important dates to note in sickle cell disease history is that in 1975, New York State was the first state to add sickle cell anemia to its panel of newborn screening tests. In 1984, a patient received his first transplant, but the transplant actually was for leukemia, but it cured his sickle cell disease. So the first known transplant in a sickle cell disease patient was in 1984. In 1995, the multi-center study of hydroxyurea in sickle cell was conducted, and it showed that hydroxyurea reduces frequency of painful complications in sickle cell disease. In 1997, periodic blood transfusions as mitigators of stroke in sickle cell was studied. In 1998, FDA approved hydroxyurea for adults with sickle cell disease, and 20 years later, FDA approved hydroxyurea for children 5 years and older. And since then, things have gained a little bit more momentum, as in 2019, we had 2 additional disease-modifying therapies available for sickle cell, including voxelotor and crizanlizumab that I will talk about. And in 2023, 2 gene therapies were FDA approved for sickle cell disease. This is the epidemiology of sickle cell disease. We know that it affects about 100,000 people in the US and 20 million people worldwide. So 1 in 365 Black or African American babies in the US are born with sickle cell disease, and 1 in 16,300 Hispanic American babies in the US are born with sickle cell disease. It has a very, very high mortality within the first few years of life, especially in underdeveloped countries. There's a high frequency in areas where malaria is endemic, because malaria was a life-threatening disease in these areas of the world, and the sickle cell trait was shown to be protective for malaria, and that's how sickle cell trait came along. But it seems like the disease got worse than malaria. So that's why sickle cell is prevalent, mostly in Nigeria, Democratic Republic of Congo, and in India, where malaria is prevalent. And this is where 90% of sickle cell patients reside. In the US, the life expectancy of adults with sickle cell disease is more than 20 years shorter than that of adults without sickle cell disease. And that is in the US, where we have all the resources, or that we think that our patients have. The genetics of sickle cell disease are really just on this slide. It is an autosomal recessive disease. It affects the beta chains of the hemoglobin protein. So the hemoglobin protein consists of 2 alpha chains and 2 beta chains, and the sickle cell mutation is in the beta globin gene. And there's a substitution on the 6th position from valine to glutamic acid, and that's the cause of this whole disease. We're going to go into the pathophysiology of sickle cell disease. This is the entire pathophysiology in a nutshell. We will go over this picture in detail in the next few slides. When I explain sickle cell disease to my patients, I explain it as an accident on the freeway. I always use this analogy, and I will use this analogy in the upcoming slides as well, because I feel like it's conceptually easier for people to understand what's going on. Imagine there's a multi-car accident on the freeway. There's lots of cars that end up getting smashed together and they're getting destroyed. Some cars who are not part of the original accident also become part of the accident because that's what's going on. They were driving really fast, or they were looking somewhere else, and they got into the accident even though they were not part of the original crash. All of this commotion led to the slowing down of the traffic. Paramedics, police cars, fire trucks, tow trucks, traffic personnel all arrived on the scene. There was some destruction of the guardrails and trees around the area. And now, so this is the scenario that I want you to imagine when you think about what's going on in the vasculature of a patient with sickle cell disease. So mutations in the hemoglobin protein lead to polymerization of the protein when under stress or it's deoxygenated. So when the red cell is deoxygenated or under stress, this hemoglobin protein, which is mutated, polymerizes, and this results in the red blood cell sickling. The sickled red blood cells are like the cars involved in the original crash. These red cells are not easily deformable and have a sickle shape. Sickle red cells have a much shorter lifespan. They usually live between 30 to 60 days instead of the normal lifespan of a red cell is 120 days. And when hemolysis of the sickle red cell occurs, this releases plasma-free hemoglobin and bilirubin into the plasma. And these sickle red blood cells are very sticky, and they attract normal cells to stick to them. Increased red blood cell sickling increases reticulocytosis. So your baby red blood cell, your bone marrow, starts to compensate for that hemolysis by making more reticulocytes. And however, we think reticulocytes are good for sickle cell patients because that's the only way the red cells are being made. But it's important to understand a high reticulocyte count in a sickle cell patient is actually a poor prognostic factor, because that tells you that there is increased hemolysis. In addition, the reticulocytes are very sticky and they increase red cell viscosity, adding to the problem on the freeway that we talked about. When the freeway crash is happening at its peak, all this multiple support staff is at the scene. There is no traffic that's going through the freeway when the lanes are completely closed. And when no cars are going from one side of the crash to the other side, we have vasoocclusion. No red blood cells are getting from one side to the other, meaning no oxygen is getting to point B. And that point B could be all the tissues of your body. So it includes bone, brain, skin, heart, lungs, kidneys, ovaries, everything. So that is ischemia to point B, where oxygen is not getting there. Red blood cell sickling recruits erythrocytes, neutrophils, platelets, and it promotes more stasis of the blood. And due to this ischemia at point B, tissues are getting injured. Parts of the body that have pain receptors experience excruciating pain due to this ischemia. However, parts of the body that do not have pain receptors suffer in silence. So we call it a silent disease because organ damage usually doesn't cause pain all the time. And an organ damage usually we see when we do blood work. When the guardrails and side roads are damaged in a major accident, it's similar to the endothelial lining of the vasculature in a sickle cell patient. Cell-free hemoglobin that's released from the hemolyzed red blood cell leads to oxygenation of iron, and that causes nitric oxide depletion. Nitric oxide is a vasodilator, and this depletion leads to vasoconstriction and endothelial damage. Endothelial damage leads to increased tissue factor release, and that leads to the start of the coagulation cascade that I know the medical students have it all memorized by now in their training. But when the coagulation cascade starts with the tissue factor being released, this leads to thrombin generation, and that tells you why sickle cell patients are at high risk for strokes and they're high risk for venous thromboembolism. When the ambulance, police, fire trucks are there to help with the accident, they are also adding to the commotion and the vasoocclusion and the damage in sickle cell disease. Patients are in a state of chronic inflammation as this accident is happening on a daily basis in the vasculature of a patient with sickle cell disease. And this is usually in a patient who's not on any kind of disease-modifying therapy. Some patients say, well, I don't have pain, I don't have severe disease, but I tell them that is not the only symptom of sickle cell disease. Acute complications of sickle cell disease is what brings the individual with sickle cell disease to immediate medical attention, and pain is the most common acute complication that we see. However, as I said, individuals with sickle cell disease have chronic complication related to organ dysfunction. That's why a multidisciplinary care approach is needed in caring for our patients. We need the support of pulmonologists, neurologists, neuroradiologists, transfusion medicine specialists, pain specialists, gastroenterologists, surgeons, endocrinologists, reproductive health specialists, nephrologists, ophthalmologists, school systems, psychologists, psychiatrists, social workers, ED providers. We need the community to help us bring the patients to us and help us with educating the patient. It literally takes a village to take care of our patients with sickle cell disease, as it does for any chronic multi-system disease. Going forward, I would like to discuss some of the complications of sickle cell disease that apply to infants, especially children under the age of 2 and 3 years of age. Sickle cell mortality is very high in underdeveloped countries for little children, more than 90%. However, in the US, it's minimal because we have access to medical care, we have access to vaccinations, we have access to penicillin prophylaxis, and that has improved the survival of our babies with sickle cell disease. However, our infants still experience dactylitis. Dactylitis is a painful swelling of your hands and feet, usually occurs between the ages of 6 months to 2 years. And the treatment for it is usually fluids, NSAID therapy, rest, hydration. Splenic sequestration is a sudden trapping of blood within the spleen. I call spleen as the gatekeeper of every cell that goes through your circulatory system. And when it sees a cell that looks like a sickle-shaped cell, the spleen wants to destroy it because it says, well, you don't belong in the circulation. You look abnormal. And what happens is that causes a backlog of flow into the spleen where blood goes in, but it's not able to come out. The gates are completely clogged up with sickle cells. And so this can actually occur in any age. It used to be, it only occurred early in life, but now that patients are on hydroxyurea and disease-modifying therapies, this can actually occur in any age of patients. Patients present with an enlarged spleen, with or without a fever, pain, lethargy, and sometimes they present in a circulatory collapse and death, which is the worst case scenario. Recurrence of splenic sequestration is quite common, 50% of the time that this occurs again. Usually the treatment when the patient presents is blood transfusions in small increments as soon as possible. Patients who have life-threatening splenectomy or recurrent splenic sequestration, they usually require a splenectomy because we don't want this to be worse and worse every time the patient presents. Fever is a medical emergency for all sickle cell patients because we believe that the spleen is actually not functional in helping with encapsulated organisms. We treat every sickle cell patient, whether or not they have a physical spleen in their body, as asplenic. So we ensure that every fever needs a hospital visit, whether it's in the ER or whether it's in the hospital. Patient needs blood cultures drawn, IV antibiotics delivered as if they were having an encapsulated bacterial infection. And we ensure that patients receive their Hib, pneumococcal, and meningococcal vaccines regularly. In children, here's a list of all the complications that can develop. I do not have time to go over all of them, but some of the major things we see in children who are not optimally managed include vaso-occlusive pain, delayed growth and development, cognitive delays in school, silent or overt strokes, acute chest syndrome, avascular necrosis. Many of our patients suffer from anxiety and depression due to this diagnosis, given what it causes. Adults suffer from all of those complications, but they also, in addition, suffer from organ damage and dysfunction in their early 20s and 30s. And that's very early to have heart failure and kidney failure and chronic lung disease. Many adult patients in the US are not receiving optimal care and are not even connected to an adult sickle cell specialist and are dying getting care primarily in the ERs and in inpatient units. This is something that is a work in progress, and we are far from perfect care at this point. Shifting gears, I would like to mention what optimal care looks like for sickle cell disease. We screen early to catch complications early enough, so intervention would help. We treat early to prevent these complications. That is a pediatric way of doing things, and that is my goal as a sickle cell provider for the pediatric population. If we do not prevent, treating is much harder for the patient's health, the healthcare system, and for the whole medical community. Once a patient reaches organ failure, our care becomes reactive, then proactive. And I really believe in proactive care. Here are the screening tests we perform for our patients in our comprehensive sickle cell clinics. So obviously every child in the US, in every state, gets a newborn screen, which tells the pediatrician of that patient whether they have sickle cell disease or not. And as soon as that abnormal newborn screen comes, the pediatrician is supposed to refer that patient to the nearest sickle cell center. Transcranial Doppler is an ultrasound that is done of the brain starting 2 to 16 years of age, and that is looking at the blood vessels and the flow through those blood vessels, looking at what patients are at high risk for having a stroke. MRI screening is standard practice starting school age when sedation is not necessary. Pulmonary function tests are done in our clinic starting 8 years of life because patients with asthma who are not oxygenating well and have severe anemia due to sickle cell have a double hit. And those are the patients that are extremely high risk for a stroke. Sleep studies are performed in patients who have nighttime hypoxemia. So we always screen, we talk about snoring, we talk about asthma in our clinic for that very reason, because if, again, oxygen not getting to the brain, red cells not getting to the brain, high risk of stroke. Pulmonary hypertension is a big problem in adults with sickle cell disease. Fortunately, I don't see that in my pediatric world, but 20s and 30s is not very late adulthood when these problems do occur. So we do start screening with echocardiograms. We do urine nephropathy screens. So we do check urine for albumin early, starting 8 years of life. We do retinopathy screens starting 10 years of life. We do depression and anxiety screening starting at 1 year of life. We have our psychologists in our clinic doing this screening for us. Patients who get lots of transfusions are at risk for iron overload, and they need liver iron concentration screenings. And then if they have iron overload, they need chelation therapy, and that can cause hearing problems, and those are the patients who need audiology screenings. the first medication we start soon after birth is penicillin prophylaxis. We do that to prevent life-threatening sepsis in our patients who have splenic dysfunction related to sickle cell disease associated hemolysis. We continue this therapy for 5 years until all our patients are vaccinated for H. influenza, pneumococcal, and meningococcal disease. Shifting gears, I wanted to talk about disease-modifying therapies that we provide for our sickle cell patients. These therapies address the pathophysiology that we discussed earlier. These are the 4 FDA-approved disease-modifying therapies for sickle cell disease. Hydroxyurea is considered standard of care for all patients with hemoglobin SS and S beta 0 genotypes. So there's multiple types of sickle cell disease, but SS and S beta 0 disease are considered the most severe forms of sickle cell disease. Hydroxyurea can be used in other genotypes. However, the studies have not been done in SC patients or S beta plus patients. The other 3 therapies that I'm going to talk about, I refer to in my clinic as icing on the cake. I say hydroxyurea is the cake, and these other therapies are the icing around it. So I really focus our attention to hydroxyurea therapy. And the reason I do that is because hydroxyurea addresses a lot of the pathophysiology that we discussed earlier. How hydroxyurea works, it is a ribonucleotide reductase inhibitor indicated for patients with SS and S beta 0. It increases fetal hemoglobin. So physiologically, it reduces sickling by increasing fetal hemoglobin. Therefore, I say less accidents on the freeway. Less red cells are hemolyzing if there's less hemoglobin S in them. Red cells live longer, which means reticulocytes are lower, which means less viscosity, which means less stickiness on the freeway. Hydroxyurea is myelosuppressive. If you think about it, hydroxyurea was invented as a chemotherapy agent, and it's still used for certain chronic leukemias. It is myelosuppressive. So less ambulances, cops, and fire trucks on the freeway where they're not necessarily always needed. If there's less red cell breakdown, then there is less need for all these. And if there are less accidents, cars are moving along better through the freeway, and red cells are reaching their destination loaded with oxygen much more efficiently, providing it to the tissues that need them, which means less vaso-occlusion and improvement in the hemoglobin levels. There are definitely some side effects associated with hydroxyurea, including leukopenia. So patients, we have to monitor their white blood cells counts when they're on hydroxyurea to make sure they're not too low. We keep their neutrophil counts between 1,500 to 3,000 because we want them to be not so immunosuppressed that they can't fight normal infections. Some patients can develop darkening of their nail beds. Some patients may develop some darkening of the skin under their nail beds. Some patients report some thinning of their hair. However, there is no reports of hydroxyurea leading to any kind of secondary malignancy in the future in any sickle cell patient so far. In multiple clinical trials so far, this is the baby hug trial that was done in 2012 in children ages 9 months and older with hydroxyurea. We have known that hydroxyurea decreases rates of pain, decreases rate of dactylitis, decreases risk of acute chest syndrome. We know patients on hydroxyurea have decreased hospitalizations, and they have decreased mortality, improved life expectancy. Hydroxyurea is a cheap medication in the US. So there are studies now that have been done in sub-Saharan Africa. So in this study, 606 children completed hydroxyurea for 3 years, and they took it There was a retention rate. So when they did this study, 94% of the patients who were in the study stayed in the study for 3 years. And hydroxyurea therapy led to significant increases in both the hemoglobin and the fetal hemoglobin levels. And they found that hydroxyurea treatment was feasible and safe in children with sickle cell living in sub-Saharan Africa. And this therapy reduced the incidence of vaso-occlusive events, infections, malaria, transfusions, and death, which support the need for this therapy being available for 20 million people worldwide and not just in the US. Voxelotor is the second disease-modifying therapy that was approved in 2019. Voxelotor forms a reversible covalent bond with the alpha globin chain of the hemoglobin, and it allosterically increases hemoglobin S oxygen affinity, and that stabilizes the oxygenation, and that leads to a relaxed, it doesn't cause that deoxygenation, and so bundling of the sickle cell. So the cell doesn't change its shape. So it doesn't change, it changes its ability to sickle. So the cell doesn't sickle as much. And it's given orally every single day. It's approved for ages 4 and over. There was a HOPE trial that I'll go over, and it showed that it increases hemoglobin levels. So if the cell is not sickling, it's living longer, hence the hemoglobin number is increasing. It decreases hemolysis. So if you think of what it helps with that damage that's going on when the sickling is happening, the accident that's going on. Long-term data is definitely pending for this medication. The biggest drawback of this medication is its side effects. Unfortunately, it's a great medication so far that we know. However, a lot of our patients are unable to continue this treatment because of headaches, diarrhea, abdominal pain, nausea, and some of our patients have developed rash. So a lot of my patients who started this therapy, unfortunately, are not able to continue this therapy. This is the trial that led to the approval of this medication. And this study showed, so if you see the lines, the turquoise color is the higher dose voxelotor, the blue line is the lower dose voxelotor, and the red line is the placebo. And you can see the change in the hemoglobin was the most in patients who received the high dose voxelotor, and the change was sustained over time up to 24 weeks of therapy. And more than half of the patients increased their hemoglobin by 1 gram per deciliter. It doesn't seem like a lot, but 1 gram of hemoglobin means a lot for oxygenation of the tissue. So we were very happy, and we must say, when you start this drug, the improvement is within 2 weeks of starting the treatment. So we see the rise in the hemoglobin fairly quickly after patients start this therapy. However, this therapy did not show a change in vaso-occlusive pain events. So this medication is not used for prevention of pain crises in sickle cell patients. So I use it as a conjunction. So when hydroxyurea has reached its optimal dosage in a patient, I add this medication to improve the hemoglobin number even further. Crizanlizumab is a humanized monoclonal antibody that binds P-selectin. P-selectin is definitely very active during the endothelial damage vaso-occlusion phase of sickle cell disease, which is why this antibody was created. It's an intravenous medication, so it does require an IV infusion, and it has to be given every 4 weeks. It's approved for ages 16 and over. It has been shown in a study to inhibit endothelial cell adhesion, platelet, white cell, red cell, and prevention of vaso-occlusive events. So the indication for this medication is for patients who are having multiple recurrent vaso-occlusive pain events. However, this medication actually was taken off the market in Europe because they did another study that didn't show benefits. I would say some of our patients do benefit from it, but the medication is not being used as often since it was taken off the market in Europe. L-glutamine is theorized to protect sickle cells from oxidative damage as it contributes to NAD+ synthesis for the regeneration of glutathione. It is, I call it a supplement that actually has been shown to decrease pain. So phase 3 clinical trial showed that it modestly decreased pain crises, hospitalization in acute chest, and used as an additive medication to hydroxyurea. Some of the side effects include hepatic and renal impairment. These are just concerns. For the most part, it's tolerated okay. The biggest issue, it's a powder that you have to dissolve, and it has the grittiness in it, and you have to drink all this fluid. It's approved for ages 5 and older for patients with SS and S beta 0 disease. Changing gears, I wanted to talk about just a little bit. I'm not a transplanter, so this is not my area of expertise, but I just wanted everybody to get a feel for what bone marrow transplant is. Bone marrow transplant is when you are changing the stem cells of the patient. So there's 3 types of bone marrow transplant. One is a matched sibling donor. So if your sibling, full sibling is a match, that is supposed to be the best type of transplant you can get for sickle cell because it has a long-term survival of over 95%. So if any transplant I ask my patients to consider, that is the one type of transplant. I say get all your, if you have any full siblings, all your siblings should be tested to figure out if they're a match. Whether or not patients go for it, it's up to them. It's a shared decision making, but I definitely say the outcomes are very good for matched sibling donor transplant, and that has been shown in multiple studies. The other type of transplants that are not well studied are not, I must say, I have fear. I usually only refer patients for those other types of transplants when they're having a lot of complications of sickle cell. And the reason being high mortality with the transplant and decreased long-term survival of these patients. So haploidentical donor transplant is a first-degree relative of the patient who's a donor. And then match unrelated donor is when you go to the registry, the bone marrow registry, and you find a matched donor. And these 2 types of transplants are still, I feel, in clinical trials.
And sorry, really quick question before we go on. We just had a question in the chat regarding the last section. So just wanted to see if we could address that first.
I'm going to read that. Thank you for directing me. Other screening tests we have. Yeah, thank you for that question. I do agree with that statement that, yeah, I say hydroxyurea cheap here, but it's not cheap in other countries, and access to care. That's a good question. I think there's a lot of efforts actually going on through the American Society of Hematology where access is being improved in Africa. There's actually many sickle cell centers. There's sickle cell centers in Jamaica. There's sickle cell centers in India. There's sickle cell centers in Brazil. However, Africa is a big continent. So, access is a big, big issue. But I think efforts are being made through the American Society of Hematology and the National Institute of Health. So these are things in the making. Also, transplant and gene therapy are becoming, considerations. But yeah, so efforts are there, but it like everything takes time. I think I did, yeah. So that study in Africa was initially where they looked at hydroxyurea. They actually found that patients were coming from 3-4 hours away to get that dose of hydroxyurea and for their blood work. And so that tells you that the need is really there. But yes, there are efforts that are ongoing. And yeah, if you're interested in those efforts, please let me know and I'll connect you to the people who are doing this work through the American Society of Hematology and some investigators who are working on this. Thank you for that question. All right, so in terms of transplant, a total of, this is data from 2022 that I saw published from the bone marrow transplant registry. About 1,000 transplants for sickle cell were done between 2000 and 2017 in 94 centers in the US. And these are the survival rates of the 1096 patients. It doesn't quite explain. I feel like 53 patients did not make it to the 1 year, 2 year, and 10-year mark. But the survival rates are good once you make it past the original transplant. But it's still 87% of patients survived 2 years after their transplant. And most of the donors here were the HLA match sibling donors that I talked about. So we do know that that is the transplant that has the highest survival rate. I wanted to take the next 2 minutes, if possible, to show this video because, again, gene therapy is new. This is the type of information I provide to my patients, but I feel like this gives a visual. So me just talking about gene therapy is going to be less exciting for you. So I'm going to click on this and see, hopefully this works for everybody to watch this. And this is from the NIH website. So, so just bear with me. I'll try to show this video.
Research use genome editing technologies such as CRISPR-Cas9 for sickle cell disease. One way is to turn on the gene for fetal hemoglobin, which can help reverse sickle cell disease. Several months after birth, a molecular switch inside our bodies shuts off the gene for fetal hemoglobin and turns on the adult hemoglobin gene. In sickle cell disease, only the adult hemoglobin is mutated and makes hemoglobin S. To turn fetal hemoglobin back on, doctors first need to collect some of the special stem cells from your blood or bone marrow. These stem cells make new red blood cells. The cell's DNA can then be edited in a lab. Scientists usually use a vector to get all the genome editing ingredients inside the cells. Vectors are molecular packaging that are made in the lab. Often vectors are made from viruses, since viruses are great at getting DNA inside of our cells. To make the vector, scientists modify the virus to remove its harmful genes that cause disease, and to add all the genome editing ingredients. One ingredient is a scissors-like protein. Another is a guide molecule that brings the scissors to the spot on your DNA that needs to be changed. The scissors cut the DNA, leaving a gap. The cell rebuilds the gap using a third ingredient of the therapy, a blueprint for building healthy DNA. In this example, the guide molecule seeks out the molecular switch gene that shuts fetal hemoglobin off. The scissors cut the DNA near the gene. The repair process disables the gene. Without the molecular switch, the cells make more fetal hemoglobin and less adult hemoglobin. These edited stem cells are returned to the body through an IV. The edited cells make healthy red blood cells. Learn more about NHLBI's research and clinical trials that support genetic therapies.
Overview of what gene therapy is. So there's two types. One is a lentiviral associated gene therapy where, like they said, they edit the virus, insert the corrected hemoglobin gene in it, and now the virus goes into the stem cell bag and kind of inserts its DNA into the patient's stem cells, and now the stem cells are returned. There's definitely some preconditioning that the patient needs because when the edited cells come back to the patient needs to be immunosuppressed. What is exciting in gene therapy compared to transplant is that it requires less myelosuppression prior to receiving, because it's an autologous transplant. If you think about it, it's your own cells that are coming back rather than donated cells. So for that reason, gene therapy is associated with low mortality. And gene therapy was approved for decreasing pain. So far, the data is showing that 2 years after receiving gene therapy, patients are having less pain. What is not known is how long it's going to last. What is it going to do to the organs? I tell my patients this all the time, that these therapies work from the time you receive them onwards. So we call them not curative therapies like we think about in cancer. We call them transformative therapies. The reason being that if you have avascular necrosis prior to you getting gene therapy, the avascular necrosis is not going to go away. It's going to hopefully stop progressing, but it's not going to reverse the damage that has already been caused. So we hope that these therapies, once we have our patients, we kind of follow them long term. And if they're safe and they last, then they're going to be approved for younger and younger patients, because what we want to do is provide it preventatively rather than later once they have had organ damage. So we hope that these therapies become more and more, first of all, we have to study them, long-term data, and then hopefully approve them for younger patients. But right now, gene therapy is approved for ages 12 and over for SS and S beta 0 patients who have a lot of pain. However, they're not approved for anybody younger. So the next type of trials that are coming up are for younger patients. However, also when therapies only work if we work together. We cannot provide these therapies if the patients are not even being seen in a clinic. So it's extremely important that we work together. Partnerships with our patients and families is essential. Barriers to care have to be addressed. Education of all involved parties is important for patients, families, healthcare providers. Given we have a whole slew of medical providers who encounter our patients, everybody who's involved in their care needs to know what sickle cell disease is. We need to involve behavioral, psychological, psychosocial community members in the care of our patients. This is the overview of our sickle cell clinic, the pediatric clinic at UCSF Oakland. As you see, we have myself as the pediatric provider. Dr. Rivers is the transition provider. We have a transfusion medicine expert. We have a med peds expert. We have a nurse practitioner, nurse coordinator, genetic counselor, psychologist, and social workers. And we also have an adult program, luckily, in our clinic, so patients can be seen in the adult program as well. And we have adult hematologists, nurse practitioners, and social workers as well. In addition, UCSF sites that are improving their sickle cell cares going forward and actually do see sickle cell patients today are UCSF Mission Bay, UCSF Fresno, and Zuckerberg San Francisco General. And all these places have a sickle cell program and are seeing sickle cell patients. And that is all I have for my talk. If you have any questions, feel free to ask now, or also if we're out of time, I'm happy to answer any questions via email as well. Thank you for listening, everyone.
Oh, thank you so much. We have about 5 minutes if there's any questions. And we also put a link in the chat for a survey, and do appreciate your feedback if you all wouldn't mind taking a minute to do that. So any questions from the audience?
I feel like there's another, oh, that's just you. All right. Well, thank you everybody for being here. And yeah, I would love to hear feedback if, especially if we want to give this talk again, I would love to hear from the audience what they would like to hear more of or less of. I'm happy to gear the talk towards that. Take care. Bye everyone. Have a good rest of your day.
Thank you.